The following movie is an in-office lateral meniscectomy with removal of cartilage flap and loose body. The patient is a 47-year-old active male who is a former Division I soccer player. He had an ACL reconstruction performed in his early 20s. He presents to the office with a chief complaint of instability in catching within the knee. After undergoing a formal consent, the patient agreed to a diagnostic needle arthroscopy with addressing of the intra-articular pathology if amenable. He was prepped and draped in a sterile manner in a procedure room, with the tablet positioned to the left with the needle arthroscopy available. Upon entering the joint, the patient was known to have a medial thermocondyle cartilage flap, which is being addressed by the motorized shaver. This shaver is a 2.9 millimeter mechanical shaver. The shaver was introduced into the knee through a percutaneous poke on the medial aspect of the knee, measuring approximately 3 millimeters. Micro instruments measuring 2.7 to 2.9 millimeters were used for straight baskets, graspers, as well as probes. Also, we used a Trice Medical in-office needle arthroscopy side post, similar to one used in the operating room. This allows the surgeon to sit at the foot of the bed and place varus and valgus thrusts on the knee to gap the knee safely and get to the regions of the knee that would allow for the working portion of the case. This post is available commercially. After addressing the medial compartment of the knee and removing the cartilage flap, attention is then placed to the lateral side of the knee. Pictured on the left, the surgeon is able to place the leg into a varus or valgus positioning by using the side post and sitting down on a rolling chair. The patient and both surgeon are gowned in sterile gowns, and the leg is placed against the surgeon's operative thigh to allow for varus entry into the medial compartment of the knee. Similarly, the leg is then swung into a varus component to allow for access into the lateral portion of the knee. As seen here, the mechanical eye shaver is used in the lateral compartment to address loose cartilage flaps as well as some chondral damage on the tibial plateau. Fluid is introduced into the knee joint by using 30 millimeters of pressure from a standard commercial pump. A straight basket is then used to perform the partial lateral meniscectomy, followed by reintroducing the shaver to remove the loose body. The patient tolerated the procedure well. At the beginning of the case, his knee was anesthetized intra-articularly with 15 cc's of 1% lidocaine plain, as well as 15 cc's of 0.25% marcaine plain. The same cocktail was used to anesthetize the working portals on the skin and capsule medially and laterally. Pictured on the left are the entry sites for the needle arthroscopy laterally, as well as one small butterfly stitch on the medial aspect of the knee. The patient was able to rise and walk out of the procedure on his own power without crutches. He was given a post-injection protocol recommending ice and elevation. He was able to return to work the same day and perform his normal job duties. At the 2-week and 4-week follow-up, the patient had reported that his mechanical symptoms had improved and he was doing quite well with home therapy.